department. We're the DPAC of cardiac ultrasound. It's really important to know where to put the probe on the chest and immediately pull up a cardiac image, because you just don't know what you're going to encounter sometimes in the heart. The heart, not the first trimester, the heart. I know we can see heartbeats in the first trimester. We're talking about cardiac transthoracic echocardiography now. Okay, switching gears, grinding a little bit, but I'm in the right gear hopefully now. So these are 3 cases where cardiac ultrasound really made a big difference. Again, these are real cases that all happened to me over the last probably 10, 15 years. This is a 31-year-old female. She came in with cough and some syncope. She was coughing a lot. She passed out. She's had basically a fever for like 6 days, despite taking, you know, the supportive care like Tylenol and Motrin. She was taking Tylenol and Motrin. What do you guys call it here? Paracetamol? Paracetamol? Yeah. Try to use the local lingo when I can. And taking it at the same time and still having a fever. She was taking NyQuil and Dayquil around the clock. It wasn't helping. She went to her primary care doctor. Of course, they gave her a Z-Pak, azithromycin. She started taking that yesterday. She's not feeling any better. She's a healthy young girl. No past medical history. She's not taking any medications. You can see her vital signs here. Her heart rate was 110. Her blood pressure, 86/50. Pretty low. She's pretty hypotensive at this point. We're starting to worry about her a little bit more now. Her respiratory rate, she was huffing and puffing 20 times a minute. Definitely febrile, 38.3. Low grade. She was, you know, starting to kick in a little bit, all these antipyretics. But still, 38.3. She's febrile. Her pulse ox is 96%. She's got scattered bronchi. And when you do your physical exam, in addition to the scattered bronchi, you look down at her legs and you're like, there's a little bit of edema down here. I'm not sure what's going on. And her influenza test came back positive. Now, in the United States, we're having a lot of influenza right now. I don't know if you've heard about this or not. We had to open up a whole separate surgery area in my hospital just for influenza. And you guys went through this already, and now it's, you know, come down to us. We're having, I think, a 36% vaccination penetration rate, and so it was a little bit off this year, although still 36% of the people benefited from it, so we still recommend it. But this person was influenza B positive, and she did not get a vaccination. So what do you guys want to do next? We get a chest x-ray, and it shows a sort of a viral pattern on the chest x-ray. Not very specific looking. You just kind of say, yeah, it's sort of consistent with their influenza B situation. So what do you think you should do next after this chest x-ray? Anybody have any ideas? And I know this is the echo, 3 cases of echo talking. I promise you we're getting there. But you know, after the chest x-ray maybe shows this non-specific pattern, we get a fresh set of vital signs. Her heart rate is very tachycardic. She's still hypotensive. This is after a couple liters of fluid. She's tachypnic. She's still a little febrile. Her pulse ox is okay. Who would want to get a CT angiogram on this patient? CT angiogram. This was being batted around on her quite a bit, and somebody actually did end up getting a CT angiogram on her, and she started to decompensate in the CT scanner. She got a little bit worse, a little bit more hypotensive, but was complaining of a lot of chest pain. So, anybody here want to do an echo on this patient? Anybody interested in doing an echo? Oh, I'm seeing some hands come up with the echo. Oh, good, good, yeah, interestingly. And this is what we see when we do the echo. So, what do you guys think is going on here in this echo? Again, she's hypotensive. She's complaining of a lot of chest pain, which is why we got the CT angio. The CT angio, by the way, didn't show any clots. But this, what do you guys think here when you see this heart? First of all, what orientation is the transducer in? Peristernal long, okay. And so, if I had to zoom in here, what is this valve right here? Anterior leaflet of the mitral valve. You guys agree with that? Right here, this is the anterior tip of the mitral valve there. Normally, what is that leaflet doing? It's coming up a lot higher and smacking into the septum, right? We want to see these two things. We want to see that mitral valve come up there and just smack that septum, you know? Bam, bam. Who's your mitral valve? Who's your mitral valve? We're not seeing that here. Okay, we're just seeing the kind of moving along there, not really doing much. And if you look at what chamber of the heart is this over here? the left ventricle. Is there a big difference between end systole and end diastole in the left ventricle? Not really, right? So what do you guys think is wrong with this patient? Why would this 31-year-old have such a poor function of her heart? Yeah, myocarditis, that's exactly right. This is what we're talking about here. So when you look up here, if you look at the, we dropped an M-mode spike on that mitral valve tip here and the interventricular septum, we can measure that distance, and this is what we call the Point Septal Separation. In this case, it was 20 millimeters. 20 millimeters. So what does that mean? How would this correlate to ejection fraction? Well, we can actually, there's been some literature shows that if you take 75.5 and you subtract that from the value of the EPSS, Point Septal Separation. This would be a good time, by the way, if you want to take a picture of this. I tend to use this equation quite a bit. It's not perfect for ejection fraction. There's other ways of being more accurate with ejection fraction, but boy, you know, as we go through our QA, we QA about 300 scans a week, and I don't know, maybe 20 of those are getting EPSSs done. We look up the echoes, and it's incredibly close. It's like within 5 or 10%, we're getting to what a cardiologist says the echo is with the fancy 45-minute complete echocardiogram with this EPSS value. So 75.5 times, what did we say that EPSS was? 20 minus 75, so 2.5 times 20 minus 75.5. Anybody have a handy calculator? I did it on the plane coming here. I was a little bit tired, and I'm not that good at math, but I got 25%. And when you look over at the heart, you go, yeah, that seems about right. It's really not squeezing very well. 25% sort of makes sense for this EPSS, Point Septal Separation ejection fraction. And so, yeah, I think that in terms of this case, when we think about what's going on with this patient, contractility, myocarditis, if I had seen this, if we had done the ultrasound first, we might have been able to avoid the unnecessary CT scan, the contrast load, and also the 1,000 chest x-rays of radiation for the CT scan. I think that would have been, and she got a little bit, her blood pressure definitely got wonky in the CT scan, and everybody kind of freaked. She almost had a little code blue event. She didn't, but everybody freaked out, her blood pressure dropped. So this patient got admitted for supportive therapy, and she actually did well. She was monitored for about a week in the hospital. She finally went home, and she recovered from this episode of myocarditis. But we all know there's been a lot of case reports with influenza where people actually die from myocarditis if they don't get the right supportive care early on. So this is a case, I think, could have gone to the executioner if it wasn't for the fact that we were right on quickly with that echo. This was her peristernal short axis here. Just rotate the transducer 90 degrees from peristernal long into peristernal short. You can see here, that's actually the fish mouth here. You see that her mitral valve here looks just like a little fish mouth. And we're kind of, if we go a little bit more distally from this view, we can see the apex. But in that case, there's not a lot of delta between systole and diastole, not a lot of squeeze there, though it is symmetric. Okay, cool. We're going to move on to another case. Oh, sorry. So this was her case. Obviously she got Tamiflu. She got some diuresis, and she went home about a week later with a 55% ejection fraction. So she actually did quite well. Her ejection fraction turned around pretty quickly. Yeah, I wondered if there would have been a slight difference if she got the Tamiflu like the day earlier when she went to the PMD. So if the PMD had had the echo, maybe things might have turned out slightly differently for her. Okay, 57-year-old female, this is the next case. She's got shortness of breath for a month. She is a university professor. I remember her distinctly. She was bed 8. She came in. She's this big international expert, so she flies all around the world and everything. So she'd come in, was sitting in bed 8. She had some shortness of breath, she said, for about a month. Short breath for a month. Okay, well, that's kind of non-specific. Last couple of days seems like it's got a little bit worse. No chest pain. Again, she's got some mild leg swelling. But it's leg swelling sort of comes and goes, non-specific. Nothing really interesting here in her past medical history. No medications, no injuries. Not only she had a gigantic external fixation device on her leg. Nothing obvious like that to give the case away. She's a non-smoker. She was, not really tachycardic. Heart rate was 95. Blood pressure 110/65. Respiratory rate was 22. Pulse ox was 94%. Temp was essentially normal. Her lungs sounded clear. Her heart sounded good. no murmurs. She did have some trace pitting edema on one leg, just trace, just kind of like if she laid on her side, maybe. I don't know. Wasn't really making much about it. We got a D-dimer on her. It was less than 500, and that's our standard for being negative. So she has a negative D-dimer, which we know is a pretty good test, generally speaking, right? Okay, but I want you to remember one thing, and that's right here. Shortness of breath for a month. That's important when you interpret the D-dimer. So what do you guys want to do? We get a chest x-ray. Doesn't show anything. Unremarkable. Anybody have any ideas? This is an echo talk. Oh, you're right, get an echo. Very good. So we go ahead and we do this echo. And this is what we see. And immediately, and then Rachel and I are going to have a nice discussion about this, but immediately I assume that the probe must be flipped the wrong way because there's no way that's the right ventricle. That's a humongous right ventricle. And that left ventricle is just, I mean, it's minuscule compared to this giant right ventricle, right? So if I play this again, but you'll actually see this is the moderator band coming along over here, so that defines this as the right ventricle. Normally the right ventricle should be like 2/3 the size of the left ventricle, because after all, it's just pumping blood out to the lungs, and the left ventricle is doing all the heavy lifting of the blood pressure, right? Bringing the blood out to the whole body. So in this case, when that right ventricle gets so big because there's a clot blocking it, now you get this RV dilation, and the LV can't get blood to it, so the LV is sort of small and empty, and the papillary muscles start touching. And cardiologists have a term for that. They call that kissing paps. Kissing papillary muscles, an empty LV. Basically because the blood's not being able to get all the way around through the lung parenchyma back to the left side of the body. So this is sort of interesting. Why would somebody who has, here's another example here of her heart. This is the same patient. You can see her right ventricle at the top of the screen is so big. Left ventricle is small compared to the right ventricle. We see a D-shaped septum there from that high pressure in the right side of the heart, making that D-shaped septum there. So why would this person with a negative D-dimer have such high right heart pressures? And she does all this international travel, or starting to wonder about a blood clot. Is it possible to have a massive pulmonary embolism in the setting of a negative D-dimer? And the answer is abso-friggin-lutely. Because D-dimers go up acutely, and then over time, if you read the literature on them, they start coming down. Now, as emergency docs, we tend to think in acute terms all the time. Our time frames are very acute and short term. But don't forget that if somebody is, ignoring the symptoms for a long time, sort of stoic, over time, that D-dimer can go down. And if you're wondering about a pulmonary embolism, keep wondering about that and look at the heart. And if you see the right side of the heart get as big or even bigger than the left side of the heart, then consider the diagnosis of pulmonary embolism. So yeah, so she actually did pretty good. I ended up looking down her legs just because I was curious. Now here's her femoral artery, her femoral vein. Superficial deep femoral arteries over here. Her femoral vein is seen right here, and you can see it's non-compressible. There's a clot down here. And so this is her right leg, right? Because how do I know that? The indicator here is to the patient's right. And Venus rhymes with penis, although she didn't have a penis, she had a vagina. So Venus vagina, you can say that. Venus penis or Venus vagina. That's how I remember what side the artery in the vein is on. It's always helpful when it's, that way. So, but yeah, so she had a right-sided femoral clot, and that explained that trace pitting edema that I saw on the right side that I blew off when I initially saw it with the negative D-dimer. It was really hard to just basically ignore this person because her D-dimer was negative. Everybody was kind of rolling their eyes at me when I went into the echo, but the echo was so abnormal, so obviously abnormal, that it really changed the direction that we took with the patient. So just an example here, the right side from the left side, and again, Rachel and I are going to talk about indicators and orientation and everything, the dot on the screen. But one thing to remember is that normally that right ventricle should be smaller than the left ventricle, and if the RV starts to get as big or larger than the LV, then you know that there's either a pulmonary embolism or something else like pulmonary hypertension that can cause RV enlargement. And when you see that, you're going to put it into a clinical context. And this clinical context was somebody who flies around the world and has shortness of breath. But the one thing that helps me all the time, again, is this moderator band. You see that up there? That always confirms I'm looking at the right side of the heart. The left side of the heart lacks that moderator. Moderator band is an electrical system in the heart. You don't always see it. You have to kind of squint sometimes. Maybe I'm catching a piece of it right there. But that's right up there. That's the idea with the moderator band. Okay. Another way that I use ultrasound for pulmonary embolism is with TAPSE, tricuspid annular plane of systolic excursion. And this is Ben Smith. He's a good friend of mine. He does a lot of amazing free and open access medical education, particularly with ultrasound. And I've learned a ton from this guy and all of his wonderful FOMED over the years. And basically, he drew this diagram of TAPSE, tricuspid annular plane of systolic excursion. And basically, TAPSE is a measure of right ventricular function. If you can measure how much that right ventricle, it moves in a corkscrew fashion, kind of like this. The right ventricle moves in a corkscrew fashion up and down. And in all of us right now, it's going up and down more than 20 millimeters. It's functioning well, right? But when you have RV dysfunction, it doesn't go up and down as well. It starts to weaken. And that might be an early warning sign that somebody has a severe pulmonary embolism. So this is another thing you can do. You can take an M-mode spike and just drop it right here where that tricuspid valve comes right into the wall, the free wall here of the right ventricle, and you can measure how much up and downness that this tricuspid valve has. And if it's greater than 20, you have a normal RV function, and if it's less than 16, you have an abnormal RV function. And so you can see here that this tracing, the MO tracing, is this sort of sine wave on the bottom of the screen there. Can you guys see that? The sine wave's kind of going up and down. And really, over time, you start to look at these TAPSEs, tricuspid annular plane of systolic excursion, and you can eyeball them in a second, even without the M mode. You start getting used to saying, oh crap, that's a bad TAPSE, or that's a totally normal TAPSE, I'm not worried about this patient, at least right now, for having RV dysfunction. And you can see this sort of going up and down here, and it's a measure of how well that RV is contracted. Does that make sense? This confused me the first few times I saw it, and then I started measuring myself, and then it got really useful and really fun. So, like I said, you can kind of eyeball them. Do you think that's a normal TAPSE or an abnormal TAPSE? I'm seeing some shaking heads. That's an abnormal TAPSE. So this patient, it's really only moving up and down. I don't know. I'd have to put an M mode on it to see, but this patient has some kind of RV dysfunction going on for sure, just based on that B mode image. When I dropped the M mode on there, and my calipers, they measured this tiny little sine wave here. They found a nice spot to measure, and I think it was like 7.8 millimeters, definitely less than 16. And in the setting of a pulmonary embolism, I would be really worried about this patient crumping on me or decompensating. Lots of things can cause RV dysfunction. Certainly pulmonary emboli can, and we did a study on that at UCI I'm about to show you here in a minute. LV dysfunction causes RV dysfunction. Sepsis, this is kind of our next area of research we're doing with TAPSE. We're looking at septic patients, and you know that when you have a septic patient and you release all these interleukins and tumor necrosis factors and endotoxins and prostaglandins, it causes vasodilation and all of that. It causes leaky capillaries, and it can actually work right on the RV itself and causing RV dysfunction. So you have to consider that. I think it's worthwhile to consider looking at a TAPSE in a patient who's septic to see how really septic they really are. But we looked at this in patients with pulmonary embolism. We had about 87 patients who came in to our emergency department. This is not published yet. We are in the process of submitting to a journal, so it's pre-published data. Please don't distribute this. But basically, you can see our box plot here. And in patients who had a small PE, these are all patients who went for a CT angio. We were worried about PE. We did TAPSE measurements on all 87 patients. And patients with a small PE had kind of normalish looking TAPSE values. So even if you have a small PE, you may have a normal TAPSE. But if you had a large PE, as defined by the language that a radiologist would use when they interpret a CT scan, then those patients all had positive TAPSE values. So it's a way to maybe discriminate a really sick patient who has from a not too sick of a patient with a pulmonary embolism. And again, I like this. Our next phase of study with TAPSE is with those septic patients. So we're going to practice TAPSEs and stuff with you guys, get really good at it. It's pretty easy to do. Now, this is the last case I'm going to share with you guys. This case was really scary. This one, I almost killed this patient, for sure. Like, I was this close. So this woman, this 38-year-old, very nice woman, she was a bus driver. She came in by the paramedics. She had sort of sudden onset, rapid onset of shortness of breath while she was driving her bus. She smokes about 5 cigarettes a day. She recently started taking oral contraceptives, and she sits on a bus all day long, just sitting there. Smoker, oral contraceptives. She's BMI of 75. She's kind of a poor historian, a little bit tough to talk to, especially because she was getting more and more altered from her vital sign derangement here. She's hypotense, tachycardic. She's puffing away at 22 times a minute. Her pulse ox seems pretty good. Her temp's normal. You know, her lungs, she's a little bit hard to examine. Her lungs are clear. Her heart, it's sort of distant heart sounds. I don't really make much of it. Now, what do you want to do for this patient? I immediately start to worry that she's having a pulmonary embolism, right? So I open up the IV fluids. I tell the nurse to go grab me that clot busting box. We have a clot buster box. It's got basically a TPA in it. And every time you crack it open, it's $4,000. So everybody's like really nervous to open it up. It's funny. So we're like, do we do it? So we brought the box to bedside. I cracked it open. And I ordered some other tests here, kind of getting some things going. Got a D-dimer. All these things are pending, an EKG, a chest X-ray. Her blood pressure continues to worsen. And the patient, I'll never forget this, the patient reaches up and grabs my arm and says, "Doctor, I think I'm going to die. Please don't let me die." And, you know, I'm usually pretty cool at work. Not a lot rattles my cage. I'm usually the funny guy. I come in and I'm like all smiles. I was kind of shitting my pants when she did that. I'm like, oh God, I hope you don't die. Oof, this is terrible. Why am I here today? This sucks. And so I'm like, and the dad is there now, and he's like, don't let my daughter. I'm like, oh, this is so much drama. So I say, you know, the nurse is like drawing the TPA up and doing everything. They're getting it ready, and then and there's a medical student hanging around me, you know, all the time, and they're like, hey, let's do an ultrasound. I'm like, of course, yes, let's look at that gigantic RV. We put the probe on the patient. We see this. Yeah, okay, so the LP is pretty empty, kissing paps, I would say, but what does that do to? It's due to an obstructive process, but the obstructive process in this case is actually not a pulmonary embolism, it's a pericardial effusion. In fact, pericardial tamponade is going on here. There's some RV collapse. I don't know if you can see it or not, but during diastole, the RV should be opening up. But when you have tamponade physiology, during diastole, the RV paradoxically collapses. And when that happens, that's the definition of tamponade. What view of the heart is that, by the way? There's no long, very good. And so I'm seeing this, and I look at the nurse, and she's like, "Doctor, would you like it?" No, do not push the TPA, right? Because this is what I mean. If we had to push the TPA on that case, I think it would have made things much worse when we went to go do a pericardiocentesis, or at least maybe she would have let into her heart more. I don't know. I could have really, like I said, I almost killed this patient. And ultrasound, once again, saved me from that process. So we looked at her IVC, by the way, and somebody who's got obstructive process of their heart, right heart, whether it's tamponade or massive PE. In this case, it was tamponade. But you'll see, this is the same patient. You can see her fluid collection is right here. That pericardial tamponade is going on here. But this is the IVC, and hepatic vein is pooching out here. I mean, this is a very obstructed picture. When I see a patient with frank hypotension in the 70s, and I see a big fat IVC, that's a big cue right there. Whoa, 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 whoa. Something's obstructed in the heart. If we're seeing hypotension, I would expect to see a flat IVC. You can argue about whether IVC for fluid, resuscitation, we can argue about that all day long. But one thing is you can't argue about is if you see a big fat IVC with obstructive process of the heart, that might be your tip that this patient is going to need a procedure really soon in order to relieve that obstruction. All right. So we did a pericardial centesis at the bedside. Sometimes we have cardiology come down and do it. If the patient's more stable. This patient was literally crashing in front of us. So myself and my resident, my medical student, we did this pericardial synthesis, and we pulled out 200 cc's of this yellowy fluid. And at the time, I wasn't really kind of connecting all the dots. I was still in the resuscitation mode, you know. But the medical student was smart and looked at everything that was going on here and started connecting all the dots and said, "What's up with that rash on her face?" I'm like, "What are you talking about, a rash, dude? We just resuscitated this patient." And I'm like, "No, look, it's like a butter. I think this patient might have lupus." And indeed, that would turn out to be the diagnosis. And we sent this fluid off, and it came back, and everything was like ding. And then you talk to her, you know, you get a better history, and it's totally lupus the more you talk to her. But somebody comes in off the street, they're crashing like that, they're grabbing your arm, you know, I think this is really where ultrasound can make a big difference. Just to show you kind of what tamponade looks like, and then I'm going to hand the reins over, and we'll be done with this. This was a different patient that I had. This patient here has several things going on. First of all, what do you see here? Oh, first of all, what view of the heart is this? Subcostal view. How do you know that? Because the liver's up here, right? When you see the liver like that, you go, yeah, totally subcostal. Okay. This is the pericardium out here. Okay. And what chamber is this? Left ventricle. So once again, kissing PAPSE in the left ventricle. This is an empty left ventricle. This is an obstructive process going on in the heart. That's the physiology. We're seeing it now. And what do we see going on here? What chamber is this? Right atrium. Right ventricle is really shriveled up here because there's this big clot in the pericardium. Clot, by the way, looks a lot like liver. It's very sono-similar to the liver, or isoechoic. When blood crashes out of solution, it becomes more dense, gets more echogenic. It looks a lot like the liver or the spleen does. In fact, if you tell me that patient's got a subcapsular splenic hematoma or liver hematoma, I go in and I'm looking all around for it. Sometimes I can see it, I don't know, because it looks just like liver or spleen. Anyway, so this patient's they had a transmediastinal gunshot wound. That's what caused this. And we see a clot there in the pericardium. We see an empty left ventricle. And then, look what's happening between the right atrium and the right ventricle. Do you see this kind of like trampoline effect or the seesaw effect? Or it's kind of dancing back and forth. Do you guys see that? Not sure if this is going to work. You guys see what's happening here? Let's see if this works. Oh, yeah, wait. So, this is what I call the John Travolta sign. If you look at what he's doing here, he's trying to tell us, if you ever see a patient like this in 30 years from now with a portable ultrasound machine, think about tamponade, because that's exactly what this kind of looks like to me. It's this kind of thing, right? My wife, I wish she was here, she's really good at doing that. But that's the idea. To me, that's tamponade physiology. But there's another way, if you don't trust the John Travolta sign, there is another way that you can use pulse wave Doppler in order to diagnose pericardial tamponade from just a pericardial effusion. Because to stick a big needle through somebody's chest wall, I mean, that is a gutsy, that's as scary as a shift ever gets, right? That, or maybe that pushing TPA, I don't know what scares sometimes. But this is, so this is the way you do, it's a sonographic version of Pulsus Paradoxus, right? Pulsus Paradoxus, if you remember back to medical school, was something to do with blood pressure in patients with tamponade. That's about all I remember. So, and that's what we're going to do here. We're going to show that using pulse wave Doppler across the mitral valve inflow tract, during diastole, blood flows through that mitral valve, okay? And the patient's breathing in and out. As we all breathe in and out, the pressures kind of go up and down in our heart. Okay, the velocity, therefore, goes up and down in our heart through our valves. As we breathe in and out, the velocity kind of goes up through our mitral valve inflow from our LA to our LV, and then it kind of goes down as we breathe out. And I can't remember if it's when we're breathing in or breathing out. It doesn't matter. It's the delta that we're about to see here using pulse wave Doppler. And it looks a little something like this. During diastole, you have the E phase and the A wave. The E wave and the A wave. The early phase of diastole, when the LV opens up and blood goes from the left atrium to left ventricle. Okay, you guys with me? This is important. The early wave, the early phase of diastole, LV opens up, blood goes from the left atrium into the left ventricle, and then that's the E, the early phase, and then there's the atrial kick as it kicks in a little bit more blood during the A wave. Now, what we're looking at here, you can see that there's two spikes. This is the inflow velocity, EA, EA, EA. Bottom line is the difference between V peak max and V peak min. If it's greater than 25%, that's physiologic tamponade. Meaning, as you're breathing in and out, if the heart is struggling to fill itself, and the velocity is greater than 25% difference as you're inspiring and when you're expiring, that's sonographic tamponade. It's kind of a complicated concept. I like to keep it very simple. All I do, apical 4-chamber view, drop that little pulse wave Doppler on it, activate the tracing, and then I see this spikes down here, and I see some spikes that are super tall, and some spikes that are not so tall. And I find the least tall spike and the tallest spike, and I take that difference, and if it's more than 25%, that patient needs a pericardiocentesis. Let me show you some examples. So here's the apical 4-chamber, and we see this effusion over here. This is the left ventricle. We put our pulse wave Doppler in the mitral valve inflow tract, and we're measuring it. It's basically 120 centimeters per second minus 180 centimeters per second divided by 180. That's 33% difference. And again, I don't think it matters when you're inspiring, expiring. You just have to remember that V peak max and V peak min are more than 25% dissimilar. That's tamponade. A little complicated, but really, really important, I think, to learn, to be that expert when it comes to whether or not we're going to stick a needle through somebody's chest wall. Here's another one here, V peak max here. I think it was 59 centimeters per second. V peak min, 51 centimeters per second. The difference is only 12.5%. In this case, it's a pericardial effusion, and there's no tamponade physiology here. Here's another one. This one I did more recently. This patient had a very large pericardial effusion. And you know, the longer it takes these things to build up, the more the patient sort of tolerates it, right? So if you get stabbed in the chest and you're totally healthy, get stabbed in the chest, you can only tolerate from 80 to maybe at the most 200 cc's in your pericardium before you end up with tamponade. And so in this case, we're looking at this pericardial effusion here, and we're seeing V peak max, V peak min, 64 minus 52, only 18%. We're good. No pericardiocentesis. Okay, so bottom line, last slide here. I like using EPSS to estimate the ejection fraction. And in the flu season, I know you guys are sort of post-flu season, but as we go into the next flu season, and some of these flu viruses can cause a lot of myocarditis, think about that. Think about looking at EPSSs in those patients. I like that idea. Think about TAPSE in identifying which patients have severe pulmonary embolisms, and I think we're going to practice a lot of TAPSE here. And also, I like the idea of these inflow velocities to, frankly, avoid doing unnecessary pericardiocenteses. And so, I mean, if I have somebody who's got a lot of John Travolta going on and their blood pressure is 70 or 80, I'm doing pericardiocentesis regardless of this inflow velocity stuff probably. But when I'm on the fence about it, I think the inflow velocity could push me one way or the other. Any questions about any of this stuff at all? Yes?
I'm just interested in is there any information or studies about the difference between EPSS and the formula you provided and eyeball assessment of valvular systolic function and say a non-expert user, given that there are technical difficulties sometimes with measuring EPSS correctly?
So is there a study to show experts versus novices using EPSS? I would say all the studies with EPSS were done basically with novices, and I think you'll feel very comfortable. The trick with EPSS is finding the exact right place to drop that M mode. You want to have it over the tip of the valve, not down towards its annulus or its base. You want to have it where the tip comes closest to the septum, and that's where you want to drop that M mode spike. Sometimes people drop it too closer towards where the valve comes off, but you want to have it towards the leaflet, the tip of the valve. Yes?
I was just going to add to that answer. If you look up Bruce Kimura, cardiologist in the US, and his CLUE examination, he's published a lot of studies on the CLUE, which incorporates the EPSS, and a lot of his studies are with medical students.
Novice medical students, and Bruce Kimura, yeah, great guy, actually, does a lot of interesting. He's a cardiologist in San Diego. Thank you for that. Yes?
Does the angle that you take with inflow Doppler matter?
So as long as, I think, the question is, does the angle matter when you do the inflow velocity with the Doppler? The nice thing is, when you're working in the apical four-chamber view and you've got the cardiac software package activated, and you're in the apical four-chamber view where the flow is running very parallel to the ultrasound beam, I think you don't have to change the angle at all, the Doppler angle. It's set up because that's the angle that most people start with when that's the view, the apical four-chamber view, which is a very parallel one. It's automatically closer to 60 and further away from 90. So let me explain that a little bit more. Cosine of theta is in the numerator of the Doppler equation. Okay? So anybody here know what cosine of 90 degrees is?
0.
I know they said there'd be no math when you got here today, but 0. Good. So cosine of 90 is 0. You don't want to have zeros in the numerators of equations. And so it's the same reason why the police officers, the Doppler is not accurate at 90 degrees. They get you all the way down the highway. That's how they're the most accurate. It's the same way with ultrasound. You want to be away from 90, closer towards 60 degrees, more parallel than perpendicular. And the apical, that's what makes the apical four-chamber, while it's probably the hardest window of the heart to reliably get, it's also the one that has so much information coming out of it when the Doppler is more parallel. That was a roundabout way to answer your question, but I don't think you need to make any angle adjustments. That's not my way to say that. As long as you have the cardiac software setting